Okay, let's start. Assalamu alaikum wa rahmatullah alaikum jami'an. Inshallah, I'm going to moderate this blessed webinar. I would like to welcome all audiences from general practitioners, pediatrician, medical geneticists, and all medical practitioners in all subspecialty. I also would like to welcome Dr. Amal Al-Hashim, the chairman of the Saudi Society of Medical Genetics. She's the one always supportive educational program. Welcome, Dr. Amal. I would like also to thank and welcome this co-sponsor company for this webinar today, Sobi company in Takeda, for the supportive always the educational program in awareness of metabolic disorders. Today, inshallah, our webinar, we are targeting of some of the treatable metabolic disorders. Our speakers today, inshallah, we're going to be 3 speakers. I would like to introduce the first speaker, Dr. Zuhair Al-Rahbini. He's a figure names in our Kingdom of Saudi Arabia. He's, mashallah, a professor of pediatrics in medical genetics in the College of Medicine in Al Faisal University. He's a consultant of pediatrics and metabolic and medical genetics in King Faisal Specialist Hospital and Research Center in Riyadh. He took over many important academic positions. He had many publications and involved in many educational programs for the residents and fellows. Welcome, Dr. Zuhair Rahbini. His talk today will be an overview of the treatable metabolic disorders. Let's start. And before start, who did not succeed for registration in the Zoom link, please open the link for YouTube, and you have to put a comment or put your name in the comments of the YouTube link, so the ECME, so you can ask for the CME hours later. Inshallah, we're going to explain this again at the end of this webinar. Please, Dr. Zuhair, start.
طيب بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. شكرا دكتورة رنا for this nice introduction, and thanks for Saudi Society of Medical Genetics. I already shared the slide, so I don't know, shall I share it again?
Yes, Dr. Zuhair, please share it again.
طيب بسم الله. موجودة؟
Yes.
طيب بسم الله الرحمن الرحيم. This is like introduction to the other research, because as I know, Dr. Sarrar will speak about one treatable disease and Dr. Diya will speak about another one. So my talk will be about overview of treatable metabolic disorders. Assalamu alaikum wa rahmatullah. This is the logo of Saudi Society of Medical Genetics. Very nice logo, as you see. This is the DNA here. This is the chromosome, boys, girls, and uncertain. So one of the beautiful really logo in the world. And we have to smile. And Rasul sallallahu alayhi wa sallam وهو مثقل بهموم أمته أو أمة بأكملها يبتسم ويستعيذ من الحزن. بسم الله الرحمن الرحيم. ما دمت تمشي مستقيما لا يهمك إذا ظهر ظلك للناس مائلا. طبعا if we speak about treatable diseases, this is حديث عظيم. الرسول حديث أبي هريرة وهو في صحيح البخاري أن النبي صلى الله عليه وسلم قال إن الله لم ينزل داء إلا أنزل له شفاء، رواه البخاري. وحديث جابر أن النبي صلى الله عليه وسلم قال لكل داء دواء، فإذا أصيب دواء الداء برئ بإذن الله عز وجل. وهذا الحديث صحيح رواه مسلم. As you know the meaning, Allah has not sent down a disease without a cure. So this is my outlines of the talk, cases, some introduction, definitions, statistics, a spectrum of diseases to show the treatable and non-treatable, and finally the conclusion. So the first case, this is the first case, 16 months old now girl. This is the first child for non-related parents, delivered in private hospital at Al Qasim, referred to us under GI surface, actually admitted on the 7th day of life with liver impairment and thrombocytopenia for investigation. She was a full-term normal spontaneous vaginal delivery. Apgar was normal. Birth weight was 2.5 kg. She was jaundiced from early life with petechial rash over the chest and axillary area. Developed hypoglycemia. Platelets was low in the range of 41,000 to 98,000 with abnormal hepatic profile, prolonged PT, PTT, and ENR was high also in the range of 2 to 2.9. Ammonia was a little bit in higher side and lactate also. And direct, she has had direct hyperbilirubinemia with normal newborn screening. On examination at that time, she was conscious and active, jaundiced, not dysmorphic, with hepatomegaly 3 centimeter, and there is no neurocutaneous manifestation. Systemic examination was unremarkable. Ophthalmology was normal exam, and audiology was normal. So we did the investigation at that, including all liver profile, CBC, alpha-fetoprotein, and just to make long story short, her abdominal ultrasound was normal, cranial ultrasound was normal, skeletal survey was normal, and MRI was unremarkable. Her urine GCMS shows increased succinyl acetone and highly increase of 4-hydroxyphenyl acetic acid and 4-hydroxyphenyl pyruvic acid, and this is reflect really underlying tyrosinemia. So the patient was started in TBC medication, nitisinone, and tyrosine restricted diet, and she was put on urocidol by our GIT team. Later on, her whole exome or molecular testing showed that she has a novel mutation homozygous in the gene of tyrosinemia. So she was treated as tyrosinemia. After that, everything is improved. Her growth parameter improving with time with follow-up in the clinic. And this is just roughly to see the her data, how it looks. Basically the PTT, as you see, this is from the beginning, and it goes down with the time, BTT and liver enzyme. So everything really normalized with time, including bilirubin also. And this is the alpha-fetoprotein, as you see also. It was above 60,000 at the beginning, and it goes down with the time. So this is a case of tyrosinemia, which is treatable disease. I know this disease from the past. I know a lot of patients died in the past because of liver failure, waiting for liver transplantation. So this is really one of the treatable diseases. The second case, this patient was liver transferred to us also with liver failure, as you see, jaundice, hepatosplenomegaly. And when we ask, this is admitted under our GIT team also, we ask for galactose metabolites, and it was high, although it is not specific in the case of liver failure. However, I went back to this patient and I examined the eye. There is cataract. So I know this is tyrosinemia. This is the patient before treatment, and this is after galactose-free diet, and you can appreciate the difference. Later on, this is really the uncle, not the father, who is holding the child. He came to my clinic later on in one day, and he put his child here in the clinic, and he said, "Doctor, my child is having galactosemia." So he is the one who diagnosed it really. Again, we put the patient in galactose-free diet. This is his liver profile, and this is the liver and the spleen with the time, and the patient, this is later on with the galactose-free diet. So if we want to speak about all these treatable and not treatable diseases, as you know, metabolic are more than 600 single gene disorders, mostly inherited as autosomal recessive, and the mutation in the gene lead to abnormal protein in the enzyme or transporter, and so on. This is what I mean by autosomal recessive. You see the consanguinity better affect male and female, and it comes in one generation transfers generation like this. This is another form of inherited metabolic diseases, basically affect the boys here, and this is X-linked recessive disorder. If we want to speak about these diseases, basically we speak about protein abnormality related to mutation in the gene. So it can affect any protein in the form of the enzyme in peroxisome, membrane, mitochondria, lysosome, smooth endoplasmic reticulum, rough, and Golgi apparatus. So any enzyme deficiency or abnormal can lead to one of these disorders. So this is the first term. It was called inborn error of metabolism by Archibald Garrod long time ago, almost more than 100 years, and he is the one who described alkapton urea. You know this. There are thousands of pathways in the cell which metabolize the different metabolites, and as I said, any abnormality in this or most of this enzyme can lead to a metabolic disorder. So basically, this is substrate metabolites. If there is a normal gene produce a normal enzyme, so the pathway goes normal substrate converted to product in the presence of coenzyme sometime. In these diseases, you will find a mutation lead to abnormal enzymes, so it blocks the pathway and it leads to accumulation of substrate and deficiency of products. These diseases are individually rare, however, collectively numerous, and it has major component of mortality and morbidity, particularly in pediatric population. Clinical diagnosis is difficult, and common clinical biochemical tests are non-specific. So when you suspect inborn error of metabolism to start treatment in these treatable diseases, you have to go to family history, very important. Early deaths in the family, if there is history of abortion, seizures not responding to treatment, and if there is index cases in the family. So I have said that most of biochemical tests are non-specific, so you have to go for a specific test for diagnosis. So basically, this is the simple, diagram to illustrate my idea. If A converted to B and B to C, if there is mutation in this gene, it leads to abnormal enzyme A2, so it blocks this pathway. B may be accumulated, go to A or D, and this is called identification of biochemical markers. So you can look for B, A, or D in form of tandem MS, urine GCMS, and to find these metabolites. Or you can go to the enzyme here itself, and this is called enzyme assay, or if you know the mutation, you go to the molecular testing. Diagnosis before treatment is very important to improve the anxiety in the family, really, even if it is not treatable, and they keep the patient coming to clinic without diagnosis. You see the family, how they are anxious. However, if you diagnose them, even if it is not treatable, the anxiety will be relieved a lot. And there is, of course, you need the diagnosis to treat this disorder as early as possible, because the time frame is very important in these disorders. Also, if they are treatable or non-treatable diseases, you can counsel the family to prevent this in future pregnancy. What is the obstacles in this metabolic disorder? Are the treatment, and there is difference between really treatment and cure. So cure really like antibiotic. If somebody get infection, you give antibiotic, he will be cured. So there is no longer, problem with this condition. However, cure is maybe manage the case, relieve the disease, but the treatment may be lifelong. However, the good news if it is even not treated completely, the good news is that researchers are constantly producing advances in medicine. So it is possible that a disease that can be treated but not cured today may be cured in the future. The fact about genetic diseases, this is a long time study in the past, a Canadian study. As you see, they look for 100% diseases, 372 diseases to see what are diseases are treatable. So they found that are totally treated are 12% only, and partially treated is 54%, and no effect of treatment in 34%. So as I said, I mean, still we are early in treatment of these diseases. However, I have said in the beginning, لكل داء دواء كما قال الرسول صلى الله عليه وسلم. And the rapid advances in understanding the molecular pathophysiology of many inherited inborn error of metabolism or inborn error of metabolism has led to significant progress in development of many treatment. The expansion of newborn screening provide opportunity for early treatment, leading to reduce mortality and morbidity. So this is a summary of the available treatment substrate converted to product. So if there is a block here, substrate will be accumulated. You can limit intake and supplement the product here. You can see if there is alternative pathway to stimulate alternative pathways here. In the enzyme area here, you can supply enzyme replacement therapy or give the enzyme through the tissue organ transplant, or lately the gene therapy, and maybe it is the cure for these disorders. The bad things about a statistic in our country, there is no national genetic and birth defect register till now. There is process now to look for that, and there is a committee now in the health council to look for this issue and to initiate this registry. However, most of the data are coming from individual study and newborn screening program. This is as you see, this is roughly the frequency of this in some of these diseases. It affects one among 1,000 newborn. So if إذا قدرنا عدد المواليد 500 إلى 600 ألف، معناه إنه at least من ال 30 أو من ال 17 مرض اللي يعالجوا بها أو النيوبورن سكرينينج موجودة، you have at least 500 to 600 newborn every year from the 17 diseases. So if you look for 600 diseases, I don't know how much we have of these diseases. This is also expanded newborn screening study by Dr. Majid and colleagues here from multi-center study, and you see the statistic here for different diseases are relatively common compared with the world. Our dietitian, as you see here, they have almost more than 1,000 patients, and this is very huge number really in one clinic to see all these patients, metabolic patients, and as you see, this is the different types of metabolic disorder, amino acid disorder, 60%, and so on. I look for long pilot study for propionic acidemia long time ago, and I look for how many visits of propionic acidemia coming to our emergency per year. And in 1997, when I came back after training, it was 13. Look how it is 100 in 2006, and just imagine how much more patient now for one disease only. Also, I look for the patient who exceed 14 years of age. This is also like small pilot study, and I found that at least 30% of our patients exceeding 14 years of age. So to treat these diseases, it is not limited to pediatrician nowadays. It is going to adult medicine, to obstetrician, to anesthesiologist, even for surgeon. I mean, they should read about these diseases because they will face all of these diseases. This is one of old patient homocystinuria, as you see. We looked for the bone marrow transplantation in different metabolic diseases. Also, this is a little bit before till 2015. And it is 100, more than 100 patients, because the priority for oncology patient really. But it is a very expensive, as you know, treatment, and it is available. Enzyme replacement therapy in our hospital. This is until 2016. As you see, we have almost 100 patients for different diseases: Gaucher, Bombe disease, Haller, Hunter, type 6, Morquio, and Wolman syndrome. This is also kind of treatment. And this is the data. You can see how much the load of these diseases on the health system. So this is just, as you see, oh dear, you have fever. I will make chicken soup for you. And the chicken is hearing here, and she said, just give him paracetamol. So to take you to treatable inherited metabolic diseases, I have to go quickly to the spectrum to see what are those and what are the non-treatable diseases. As you know, there is no international classification of inherited metabolic disorder. So people classify it depends on the accumulation of substrate. Like if the substrate is glycogen, they call it glycogen storage disease, and so on. Or product deficiency, like what happened in urea cycle. So urea cycle called because urea is deficient, or the site of the enzyme. So if the enzyme in mitochondria, they call it mitochondrial disorder. If it is in lysosome, they call it lysosomal storage disease, and so on. However, the most important, I will take you to clinical classification that depends on this fact. If there is a block here, there is accumulation of complex molecules like mucopolysaccharide or glycoprotein or so on, or a small toxic substance, or energy deficiency group. So the complex group is basically Golgi aperitis, peroxisomal, or lysosomal storage disease. A small toxic group is carbohydrate intolerance like galactosemia and tyrosinemia, or organic acidemia or amino acid disorder like MSUD and urea cycle. Group 3, there is deficiency of energy, the ATP, and this is related basically to glycogen and fatty acid oxidations defect. So in group 1, the disease is progressive. There is no metabolic derangement. There are examples of these are lysosomal storage disease like mucopolysaccharidosis. I am sure you will hear about treatable diseases with enzyme replacement therapy, mucolipidosis, oligosaccharidosis, Bombe disease, sphingolipidosis, and Niemann-Pick type C. So different lysosomal storage diseases, and this is a really huge number of disease, a big number of disease, reaching more than 50 disorders nowadays. So what you see in these diseases, you might see patient with coarse faces like this. This is sibling. This is the younger, older. You can appreciate the how the coarse face is getting more with age. There is bony changes, umbilical hernia. So this is Haller disease. And if you look to this patient, boy with clear cornea and same picture, coarse faces, umbilical hernia, dysostosis multiplex in the skeleton, and this is Hunter disease. You can see this appreciate coarse faces early on life, like what happened in eye cell disease in this patient. So he looks like Heller, but the presentation coming earlier. So this is coarse face is one of the presentation. You can see patient with non-immune hydrops fetalis. As I have said, the disease is progressive. So in utero, the onset started early, and the disease goes in progress till delivery, and you will see patient with non-immune hydrops fetalis with ascites, pleural effusion. If you take pleural type of this pleural type of ascitic fluids, you will see this foamy histocyte lymphocyte filled with vacuolated lipid, and you will see foamy histocyte in the bone marrow. This is GM1 gangliocytosis with gangliocytosis with which confirmed by molecular testing. The other one is the toxic compound. This is patient who present with recurrent and acute metabolic derangement because the molecules is small, Biological diagnosis is easy because you can look for this biological markers, and the treatment is easier by removing the toxic metabolite by dialysis, special diet, as I will discuss later also. One of these, the branch chain amino acid disorder. The second step here is maple syrup urine disease. You need to restrict leucine, isoleucine, valine in these diseases. If you go down, this is propionic and methylmalonic acidemia. You need to restrict isoleucine and valine in addition to methionine and odd fatty acid. So this is the patient, how they look: toxic after few days of birth, and lethargic. They look like septic patient. If you don't recognize this patient, you can delay the treatment and the complication will be more. You will hear more about tyrosinemia today. Basically, it is in tyrosine pathway. The block is here in fumarate acetoacetate, the enzyme deficiency. Toxic metabolite will be accumulated here. So you need to, we have this NTBC drug, which block the pathway early here, and you can avoid this toxic metabolites. Energy deficiency can present with fatty acid, with the failure to thrive, cardiomyopathy, sudden infant death syndrome, malformation, hypoglycemia, hyperlactic acidemia, and myopathy. One example of this, glycogen storage disease. As you see, liver is increased. There is early morning hypoglycemia. If you look to the liver here, it is filled with glycogen. Another example is VLCAD deficiency, very long chain acyl CoA dehydrogenase deficiency. Again, the patient present with hypoglycemic attacks, hepatomegaly, hypotonia, and so on. So if we speak about treatable diseases or management after diagnosis, there is emergency treatment and long-term treatment. In group 1, the complex molecules, there is no emergency metabolic decompensation because the molecule is big, complicated, stay inside the cell. So there is no really acute emergency metabolic acidosis or hypoglycemia or so on. However, in group 2 and group 3, the toxic metabolite and energy deficiency, you have emergency presentation like hypoglycemia, acidosis. So you need to remove toxic compounds, hold breastfeeding, normal formula, and correct and prevent metabolic derangement and hypoglycemia. Hydration is very important. You have to be very careful about cerebral edema and overhydration. Try to correct acid-base balance, especially if pH is very low. You need to individualize rehydration schedule. So every patient different from the other and treat infection. So there is also a specific treatment. You need to maybe continue enteral feeding, TBN. Patient might need hemofiltration or hemodialysis or peritoneal dialysis to get rid out of the toxic substances. What is about long-term management? As you know, you need this to restrict diet, toxic removal, and substrate reduction for life. The block is here, so there is substrate accumulation. As I will discuss some of this issue quickly. So this is the different enzyme replacement therapy, cofactor replacement, and dietary replacement for products. So dietary therapy, one example, this is the cornerstone of many diseases, especially the toxic and energy deficiency group. One example of this is PKU. PKU is deficiency of this enzyme, phenylalanine hydroxylase. So if there is a block here, phenylalanine will be high, tyrosine will be low. So you need to restrict phenylalanine and tyrosine. There are different formulas, of course. One of the important therapy now, large neutral amino acid and glycomacropeptides for PKU. So it is basically large neutral amino acid supplement and glycomacropeptides for PKU patient. Basically, patient will have elevated phenylalanine. So if you give this large neutral amino acid, it will be competed with phenylalanine at blood-brain barrier. So more of these go inside the brain, less phenylalanine, and you can correct the cerebral metabolites inside brain. As I have said, glycomacropeptide, one of the treatment supplement, it is found in the whey of the milk, as you need 20% of the milk is whey, and glycomacropeptide is forming 15 to 20% of these. So it is deficient of phenylalanine, so it can be supplemented to patient. It shows good result as many published study for this. Another example I have mentioned it for dietary restriction is MSUD, propionic acidemia, methylmalonic acidemia. You have HMG, isovaleric. So many diseases in this pathway. You need to restrict diet. Compliance is very important in this disorder because it is lifelong disease with restriction of diet. Toxic metabolite removal, the another way. So the important here, the most important example here is the urea cycle. So you can give benzoate or phenyl acetate to get rid out of this ammonia, and this is can be used in emergency treatment as well as on long-term treatment for urea cycle disorder. Carbaglu is one of these also treatable medication in urea cycle. It can be used in propionic and methylmalonic acidemia because propionyl CoA and it blocks the NAGs here. So if you give Carbaglu here, it is like competitive it activate the enzyme here, the NAGs, and you can bypass the block here. It is very effective, really, from my experience in hyperammonemia secondary to organic acidemia. Cofactor replacement, some of these enzymes are partially deficient and it might respond to the mega dose of the cofactor. This is many example. You have mebelseroburin disease, thiamine responsive form. You have pyridoxine, vitamin B6 in homocystinuria, and so on. So there are rules of cofactor in treatment, treating this inborn error of metabolism. Substrate reduction, I am sure Dr. Daya will speak more about this. Example is nitisinone, NTBC. So it reduces the accumulation of this toxic metabolite. That's why it is called substrate reduction therapy. Another example is miglostat in storage diseases. It blocks the pathway here earlier, so you prevent accumulation of the storage material. It is used in different diseases, include miglostat and eligolostat in Gaucher disease and in Niemann-Pick type C. Enzyme replacement therapy, also one way. So the enzyme, if it's deficient, you can give the enzyme replacement directly, the enzyme missing, or you can decrease the level by different way, different enzyme. So enzyme replacement therapy, there are many diseases now use the enzyme replacement therapy in Gaucher disease, Pompe disease, mucopolysaccharidosis. I am sure you will hear more from Dr. Sarrar about enzyme replacement therapy today. Enzyme substitution therapy, it is not the same enzyme missing. So here, one example is phenylalanine ammonia lyase, bigylated phenylalanine ammonia. What happened here? You give this enzyme, so you will enzyme work in phenylalanine that produced by bacteria in the gut to be broken down to ammonia and cinnamic acid here. So it is used and approved by FDA nowadays for treatment of PKU also. cell or organ transplantation, it is like enzyme replacement, but you give the enzyme in the form of tissue, either bone marrow or liver transplantation. And there are different lysosomal storage disease that can be treated by either bone marrow transplantation or liver transplantation. There is good experience in liver transplantation in organic acidemia, BA, propionic, methylmalonic, and MSUD also. Chaperone is one treatment, so it is basically stabilized. The chaperone stabilized the unstable enzyme. And one example, so it is oral, هذا easy, and it is coming in advantage over enzyme replacement therapy. It is used in Fabry's disease also nowadays, the miglostat. Gene therapy, I think it is the cure part of these disorders, since you give the gene or treat the disease by the missing gene, so you will correct this disorder. There are many studies now and research in these fields for many diseases. Just go to Google or PubMed and go to gene therapy to metabolic diseases or gene therapy with different metabolic diseases. You will find huge research and study in this field. Also, the area of CRISPR-Cas9 system for gene editing is coming also in the field. I will call this century, really, it is the century of treatment of genetic disorder by gene therapy. So at the end, if you look to the different modalities of treatment, you will see different ways, like product replacement in the form of the diet and substrate restriction is the main things in treatment. And you can find different ways of treatment, as I have mentioned. It depends on the disease and then different way of treating these disorders. However, after speaking about treatment, I believe the best way for these diseases is prevention. Different way of prevention, premarital screening, BGD, and prenatal diagnosis. So at the end, I will conclude by this understanding of pathophysiology of many inherited inborn error of metabolism, leading to discovering the treatment that we could not even imagine a few years ago. With advancing in early detection in newborn screening or whole exome sequencing, early treatment can be offered to patients before onset of disease manifestation for optimal outcome. Further research is needed into disease pathophysiology, combination therapies, and optimal therapy timing. So thank you very much. I am almost on time, as I given the time 45 minutes. طبعا مفهوم ولا أعيد لكم الدرس؟ لكن at the end, I would like to thank all audience, and special thank really to Dr. Mahal Itabi, who gave me some of her slide for today's presentation. Thank you very much.
Thank you, Prof. Zuhair. I think your talk صراحة in your experience reflect your long journey in experience, and it's noble. MashaAllah, you run through all the most of the metabolic disorders, and this is a good benefit for the audience as well. I think we can take a break for the prayer time. We will start again, inshallah, the webinar at sharp 7:10, and we will introduce the second and third speaker, inshallah. Again, because the Zoom capacity is maximum 1,000, so the one who failed to attend the Zoom link, The registration can be directed to the YouTube link. And in the YouTube link comment, you can put your names, so the CME hours will be, inshallah, to be accounted. The CME hours will be provided only for the one who attend for 70% of the webinar. يعني لازم تحضروا أغلب الويبينار. So who will sign out or leave before that time, he will not provide it CME hours بالتذكير. So I think, inshallah, we're going to leave now and we will come again at 7:10. So good luck. Okay, let's start. Assalamu alaikum wa rahmatullah. Welcome again. Inshallah, I'm going to introduce the second speaker, Dr. Dia Arafa. He is a consultant of medical genetics in Maternity and Children Hospital in Makkah region. He is the head of medical genetic department in Maternity and Children Hospital Makkah region since 2008. He's also the newborn screen coordinator of inborn error of metabolism in Makkah region. He participated in as a speaker in many local conferences for metabolic disorders. His talk today is about the awareness of tyrosinemia type 1. Welcome, Dr. Dia Arafa. The mic is yours.
Thank you, Sharon, for your introduction. I would like first to thank the Saudi Society of Human Genetics and the organizing company, sponsor company, for organizing and arranging this webinar scientific meeting. I will talk about tyrosinemia type 1, and I think it is very important because in the past, the only treatment for tyrosinemia was liver transplant. But nowadays, there is a specific and important effective treatment for tyrosinemia, which increase the survival rate more than 90%. So my talk will be divided on the following subject. First, I will highlight some question might be asked by the audience, and the pathophysiology of tyrosinemia, and what is harmful metabolite that exert the damage and injury to the organ, mode of inheritance and prevalence worldwide and in certain part of the world, the clinical feature and the common forms of tyrosinemia, how to diagnose tyrosinemia, specifically mentioning about importance of measuring succinylacetone in the blood or urine, and what are differential diagnoses that mimic presentation of tyrosinemia, what is the treatment available, specifically explaining or showing the medication NTBC, which was mentioned earlier by Dr. Zuhair, and how to monitor follow-up patient in the clinic with tyrosinemia, what is the prognosis for untreated and untreated patient, and how to prevent recurrence of tyrosinemia in the family, because we know that it is inherited disease. And if we have a time, we can answer some question as a revision. So when anybody see the topic about tyrosinemia, he might or she have
Dr. Dia, can you share your slides, please?
question
We cannot see your slides.
We will see. Okay. You can see now. Can be seen?
Not really, no. At least not for me. Dr. Dia, I think you need to share your screen.
I think, Dr. Dia, there is an option to share your screen with the audience or the attendees.
ها؟ لا دكتور سرار يقول ماني شايف. Yes, I will continue. It seems some misunderstanding in the presentation. So, the genetic the gene on is the H and other we will mention that success for the gene. We can test either by pre-change or by anti and oftenly abortion. Maybe they have intention for supplying TBC for long-term to tyrosinemia. Prevention is important for them. So does tyrosinemia happen more often in earthen ground? We'll see this in the prevalence that it is common in Canada and Scandinavian countries because of found. This pathophysiology showing the pathway and metabolism of tyrosinemia. Okay. Why I cannot start video? It is written you cannot start video because the host. So this is pathophysiology for tyrosinemia. The end product.
Dr. Dia, we cannot see the screen now. Okay, so I think
you can hear me.
We're gonna take. I can hear you, but there is no shared screen. I cannot see your presentation. So I think we're gonna just pause for a few minutes just to sort out this problem because of the technical problem. Okay. Welcome back. Sorry for this technical issue. We're going to move to the third speaker until this technical problem solved. The third speaker, Prof. Sarrar Muhammad, he's one of the greatest and well-respectful doctors practicing metabolic in genetics in Prince Sultan Military Medical City in Kingdom of Saudi Arabia. He is a consultant, professor and consultant in metabolic pediatric, and he's a membership of many society of inborn error of metabolism in UK and in the Middle East. He had many publications of rare disorders, and he participated as a speaker in many local and also many international conferences of metabolic and rare disorders. His academic and educational experience both are noble. Welcome, Dr. Sarrar, and the mic is yours.
Sarrar started, or I can resume?
Okay, good. Alas, can you give me the access now, please?
Welcome, Dr. Sarrar, and sorry for the audience and attendees for these technical problems. You can share your screen, Dr. Sarrar.
Sure. Okay. Can you see my slides now, Dr. Rana? Yeah?
Yes, yes, I can see.
Okay.
Very clear.
Okay, great. So let us start. نقول بسم الله والحمد لله والصلاة والسلام على رسول الله. Thank you, Dr. Rana. I haven't heard the introduction, but I'm sure it was good. Okay, so today my assignment is to talk about mucopolysaccharidosis type 2 as one of the treatable metabolic disorders. Just looking at the variety of participants here, I decided to lay the ground of this talk by just talking in a little bit of not details, about lysosomal storage diseases, and then I will give mucopolysaccharidosis before starting our assignment, which is talking about mucopolysaccharidosis. So because of the short time and the delay due to the technical problem, I apologize for that, and I will be a little bit quicker. Okay, so I might just skip some slides and go through the slides as quick as I can. Right, so in the first few slides, we'll talk about lysosomal storage disease, and then we lay the grounds for mucopolysaccharidosis and MPS 2, and we'll talk in a little bit of details about the genetics, the pathophysiology, clinical presentation of mucopolysaccharidosis type 2, and then we'll embark in the management. And here I'm going to concentrate on the clinical trials on idiosulfase, the enzyme responsible of MPS 2. And then we'll talk about the new things in the management of mucopolysaccharidosis type 2. So let us start with lysosomal storage disease. We know that the lysosomes are organelles, cell organelles, and they contain enzymes. And the main responsibility of lysosomes is is to recycle actually the macromolecules, either the indigenous macromolecules or the exogenous. And this is done by two mechanisms. One is autophagy and the other is phagocytosis. And this is done through a series of enzymes. If any one of them is missing, then we will have a phenotype responsible of that. So just quickly, the pathophysiology of lysosomal storage disease is basically due to accumulation of substrates. And these substrates are accumulated due to deficiency in an enzyme, which is caused by either mutation in a gene or due to transporter defect. So this will lead to impairment in autophagy, and this will lead to accumulation of some protein and dysfunction of the mitochondrial organelle. And this will lead to cellular stress, will lead to release of cytokines, and at the end will lead to cell death. So this is in general the mechanism of lysosomal storage disease and mucopolysaccharidosis as well. And this is an example of normal fibroblast with normal lysosomes. And the other one on the right side is lysosomal enzyme deficiency leading to accumulation of this storage disease. So this is how the cell looks like when you have deficiency of one of these enzymes. Right, so how common is lysosomal storage disease? Well, we know that there are around 6,000 to 8,000 genetic diseases existing, and out of these 600 are due to inborn error of metabolism. So that is 10% of genetic diseases are due to metabolic disorder. Okay, and out of this 600, 60 lysosomal storage diseases exist. So this again, 10% of inborn error of metabolism are due to lysosomal storage disease. And out of this 60, there are 7 mucopolysaccharidoses. So this is roughly around 10%. So this is a rule of 10. Genetic diseases, inborn error of metabolism, lysosomal storage disease, and then mucopolysaccharidosis. And generally, the incidence of lysosomal storage disease is around 1 in 7,000. However, in certain areas, the incidence might be up to 1 in 50,000. Yeah, this slide shows a result of a study done in Australia looking at lysosomal storage disease, and they found that the commonest is Gaucher. Actually, Gaucher is the commonest lysosomal storage disease worldwide, followed by MPS1 in Australia, and then the other lysosomal storage disease. And all mucopolysaccharidosis are around 25% of this cohort. Right, so this will lead us to mucopolysaccharidosis, which is basically due to accumulation of a substance called glycosaminoglycan or mucopolysaccharides. And this is accumulated due to deficiency of one of the enzymes. This substance is important in connective tissue, especially skin, cartilage, and bones. There are main 4 types of glycosaminoglycan, and that is chondroitin sulfate, dermatan sulfate, keratan sulfate, and heparan sulfate. This is another cell with normal lysosomal enzymes, and another one due to accumulation of mucopolysaccharidosis or mucopolysaccharides or GAG due to deficiency of one of the enzymes of mucopolysaccharidosis. We know that there are 7 mucopolysaccharidosis types existing. Okay, type 1, type 2, 3, 4, 6, 7, and 9. And
Dr. Sardar, sorry for disturbing, but you can raise your voice a little bit. Some audience,
okay,
they
sure.
cannot hear clear, okay? Thank you.
Sure. Okay, so as I said, there are 7 types of mucopolysaccharidosis, and that is type 1, type 2, 3, 4, 6, 7, and 9. And there are subtypes as well. For example, type 1, there are 3 subtypes, and type 3, there are 4 subtypes. And all these types depends on the enzyme defect and the accumulation of the GAGs. For example, dermatan sulfate and heparan sulfate is accumulated in type 1, type 2, and type 7. And these are characterized by multi-system involvement. And the type of the GAG accumulated will lead to the clinical presentation. For example, dermatan sulfate, favors accumulation in elastic fibers, while heparan sulfate favors neurons. So patients with accumulation of heparan sulfate will present with neurological symptoms like MPS type 3, while patients with accumulation of keratan sulfate would present with mainly bone and cartilage problems like MPS type 4. Right, so the pathophysiology is not different from other lysosomal storage diseases due to accumulation of this substance, GAG, which will lead to cell stress, will lead to release of cytokines, and will lead at the end to apoptosis. Right, mucopolysaccharidosis are one of the early genetic diseases described, and the first one was described by Charles Hunter in 1917, and then Morphew was described in 1929, and the last one was mucopolysaccharidosis type 9, which was described in 1996. Right, so mucopolysaccharidosis is a multi-system disease, and it can affect all systems, including the CNS. So some of this disorder presenting with developmental delay, with cognitive impairment, with hydrocephalus, and with hyperactivity, and so on. While others may present primarily with skeletal manifestation, including short stature, kyphoscoliosis, and hip dysplasia, and so on. While others may present with coarse facial features. Actually, most of them, they do have coarse facial features, unless there is some residual enzyme activity there. Okay, some of them, they present with corneal clouding and hearing loss, apnea and sleep problems, obstructive sleep apnea, cardiomyopathy, valvular lesions, hepatosplenomegaly, and so on. So the presentation is really involving all the systems. Right, so we really need to know when we see patients with mucopolysaccharidosis, or the most likely diagnosis is mucopolysaccharidosis, we need to look into which type of mucopolysaccharidosis. So if there is multi-system involvement with skeletal involvement and CNS, the most likely diagnosis is MPS type 1, type 2, and type 7, especially the classical type of type 1 and 2. They do present with CNS problems, that is developmental delay. If there is no cognitive delay, then one would think of type 6 and type 4. Okay, and if there is more of skeletal involvement, then the most likely diagnosis is type 4. If there is skeletal development involvement with some multi-system involvement, hepatosplenomegaly, and so on, then type 6 would be the most likely diagnosis. If there is no, or there is little multi-system involvement, little skeletal involvement, only CNS, like hyperactivity and developmental delay, then the most likely diagnosis is MPS type 3. So in summary, if the CNS is primarily involved without involvement of other systems, then the diagnosis is MPS type 3, Sam-Philippus syndrome. If the skeletal system is primarily involved with normal cognitive function, then the diagnosis is MPS type 4. And if there is multi-system involvement with skeletal involvement as well, then one would think of type 1, 2, and 7. And if there is soft tissue and skeletal involvement without CNS, then one would think of type 4 and type 6, and the accumulated type 1 and 2 as well. So how do we diagnose mucopolysaccharidosis? Well, we need to have high clinical suspicion from the symptoms and signs. We need to look at the family pedigree, if there is family history of similar condition, and if boys are more affected than girls and so on. So you need to analyze the family pedigree. And then do skeletal survey. This is really missing nowadays with people jumping to do whole exome. They sometimes forget to do skeletal survey if they suspect mucopolysaccharidosis. And we used to diagnose mucopolysaccharidosis only by doing X-ray. So I'm going to go through this quickly. Okay. So if the suspicion is high, then we need to send urine for mucopolysaccharides or glycosaminoglycan. Okay, and if it is positive, then we will send blood for enzymes. Okay, and the ultimate diagnosis is confirmed by genetic study, either single gene if you have good suspicion of one of the types of mucopolysaccharidosis, depending on the GAG profile and the clinical presentation. So you can do Sanger sequencing of a single gene, or if you are not sure, then you can do gene panel or even whole exome sequencing. Right, you might be lucky to see vacuolated lymphocyte. It is non-specific, but it is suggestive of the diagnosis. Skeletal surveys is important, as I said, so you need to do the skull X-ray, and you might see the J-shaped cella. Okay, spinal X-ray, you might see a peaking of the vertebra or wedging of the vertebra. If you do X-ray of the chest, you might see what we call oar-shaped ribs or thickened ribs. And if you do hand and foot, you might see, short, broad phalanges and metacarpals. So these X-ray findings are really highly suggestive of mucopolysaccharidosis if you see these findings. Okay, this is the cella turcica, and this is a J-shaped cella. But it is important. But having said that it is important, it is really not very reliable, difficult to identify, and it is really not very reliable. X-ray of the hip is important, and you might see hip dysplasia as seen here. This is a normal hip here, and there is dysplasia of the hip, and this patient has MPS type 1. Okay, you might see more destruction of the hip with progressive subluxation, and like in this patient with MPS type 4. And these patients usually present with painful arthrosis. And some of them, they even might need hip replacement. Okay, X-ray of the spine, you might see C1, C2 instability, hypoplasia of C1, or even stenosis of the spinal canal. Okay, so sometimes you can see the subluxation of the cervical spine by X-ray. However, you need MRI to pinpoint the subluxation and maybe to identify any spinal canal stenosis and compression as seen here. This is the X-ray here, suggestive of subluxation. However, in the MRI, it is clear there is canal stenosis, and even there is cord compression. And here, this is more clear, the cervical canal stenosis and instability, and here it is also more clear. And ultimately, this might lead to cord compression as seen here. Right, so doing X-ray might be normal early on. but you may see some findings. For example, this patient has MPS type 1, only 4 months old, but you can really identify subtle findings. Like if you look at the ribs here, they are more broad, more oar-shaped. And looking at the X-ray skull with some imagination here, you can identify the J-shaped cella. And here the X-ray of the bones, it is a little bit wide and short. And the X-ray of the hip here seems to be normal in this kid. Another patient that is 2 months or 2 years old. So the signs are more clear here, and you can clearly see the ribs, wide ribs here, and you can see the hip dysplasia and the polyp-shaped bones of the hands. And here you can see what we call Madeline deformity. And here there is widening of the space between the radia and the ulna. Another patient with MPS type 4, and here the kyphoscoliosis is more clear. And as I mentioned earlier, in MPS type 4, the skeletal manifestation is more prominent, as you can see here, the modeling deformity and the hip dysplasia as well. Another patient with MPS 6 with some of the skeletal manifestation we spoke about. Right, so if you diagnose patient with mucopolysaccharidosis, how do you manage these patients? Okay, well, you need really multidisciplinary team, a multidisciplinary approach. So you need to involve almost all subspecialties in your hospital, including the cardiologist, if there is cardiomyopathy or valvular lesion. You need to involve your orthopedic surgeon if there is skeletal problem, your ophthalmologist looking at the eye, and if there is clouding of the cornea, ENT specialist. Some of the patients may present with hearing difficulty, conductive, or even neural deafness. Right, so that is that is from the multidisciplinary approach point of view. However, we have a specific treatment for some of the mucopolysaccharidosis, I should say, especially enzyme replacement therapy. And now we know that the enzyme replacement therapy is approved and established, and there is long experience with enzyme replacement therapy for type 1, type 2, type 4, and type 6. And recently, there is enzyme replacement therapy for type 7 approved, and there is clinical trials on type 3. So almost all mucopolysaccharidosis now we do have enzyme replacement therapy for them, either established or ongoing. The other option for treatment is bone marrow transplant. Again, this is indicated for type 1 in the first 2 years of life. So if you have a patient with MPS 1, less than 18 months or less than 2 years, I think the bone marrow should be offered. This is with enzyme replacement therapy. For type 2, there is really limited experience. I'm going to talk about this later on, just to show the recent review on the bone marrow transplant for type 2. Also, studies on gene therapy are ongoing. Right, so from here we can start our business. I'm talking about the mucopolysaccharidosis type 2. So we'll talk about the genetics, the clinical presentation, and then we'll embark into the clinical trials for the enzyme replacement therapy. And then we'll talk about the data, the long-term data, and we'll answer the question, would enzyme replacement therapy increase the survivals of these patients or not? And then we'll talk about the recent advances in mucopolysaccharidosis type 2. Okay, so what is MPS2? The other name is Hunter disease. It is an X-linked disease. It is caused by deficiency of the enzyme iduronate 2-sulfatase or IDS enzyme, and it results in accumulation of glycosaminoglycan, especially heparan sulfate and dermatan sulfate. The first report published in 1917 by Charles Hunter, who described two brothers at the age 10 and 8, presenting with hearing loss, short stature, macrocephaly, coarse facial feature. And both of them died in the second decade. So that was the first report, and obviously the name of the disease is Hunter, according to this gentleman who described the disease. Right. It is, as I said, it is an X-linked recessive disorder, and usually the mother is a carrier for the gene, okay, and the father is normal, okay, and the mother passes the mutated gene to 50% of her affected males and 50% of her daughters. Okay, so the chance of being affected is 50% of daughters and 50% have the chance of being carrier actually is 50% for girls, and 50% of boys will be affected because it is an X-linked recessive. The other scenario, if the father is affected, which is really rare, however, it can occur with attenuated type of MPS2. So the gene is located in the X chromosome. So the father is going to pass the mutated gene to all the daughters. So all daughters will be carrier, while all boys will be normal. Right, so what about the prevalence of this disease in MPS2? It is variable. You know, it is in Denmark, for example, it is 0.27 in 100,000 live births, while in Portugal, it is more than 1 in 10,000. So it is common over there. Generally speaking, MPS2 is more common in Asian ethnic groups, in Japan, in Korea, in China, in Taiwan. And it's also common in Morocco. So if you compare this with MPS type 3, which is common in Europeans, in German and Dutch, and in Australian as well. In Saudi Arabia, we don't have epidemiological study, but my gut feeling is that type 4 is the most common type, coupled with type 6. And then comes type 3. And you know, we don't see a lot of type 2. So we really don't have epidemiological data, but this is just the impression from what we see in the clinics. Right, so what about the genetics of MPS? As I said, the IDS gene, mutated IDS gene is the cause of MPS phenotype, and this gene is located in the X chromosome, XQ28. It consists of 9 exons, and it encodes 550 protein. Most of the patients of the families, they carry private mutations. So more than 600 mutations were identified. And there is also a pseudogene, IDS-like pseudogene, and it is located near the IDS gene, and it does affect the phenotype of the IDS gene. Well, this slide doesn't show well because it is 17 years old. I was very, very excited to present this report in Japan, that is in 2006. I presented a young girl with Hunter syndrome due to pallus translocation. As I said, it is an X-linked recessive condition, and usually females are spared. They don't present with symptoms and signs. However, there are very few sporadic cases, and this is one of them. And this patient had balanced translocation. We were very excited at that time because genetics was not well developed, and just doing the molecular genetics was really, it was fun. Okay, so that is the crystal structure of the IDS protein. And here is the gene, as I mentioned, there is IDS gene and there is a pseudogene. And this in pseudogene, there is exon 2, 3, and intron 7. So, well, the makeup of the mutation is variable in MPS2. Most of the mutations are due to missense variants, and some of them are nonsense. Large deletion, not very common, and around 1/4 of all variants are due to large deletion. There is no clear genotype-phenotype correlation in patients with MPS. However, patients with neuropathic type, as I mentioned, there are two types, neuropathic and non-neuropathic, or rapidly progressive and progressive type. So the rapidly progressive, which is neuropathic type with CNS involvement, most of the patients, they do have nonsense mutation or they have large deletion. However, some of them, they do have missense mutation. But when it comes to the non-neuropathic type, most of the patients, they have missense variants. So there is no clear phenotype, genotype correlation, but if you have a patient with large deletion or nonsense mutation, it's likely to be the Hunter Outcome Survey is really great database. It was established in 2005, and they collected data on patients with MPS, and nowadays there is more than 8,000 patients in that database. So we have learned a lot from this Hunter Outcome Survey. I'm going to present some of the data from that survey. Right, so the pathophysiology is not really different from what I mentioned. The enzyme is, when it is deficient, there is accumulation of dermatine and hyperalpha, as I mentioned, and due to stimulation of the inflammatory cascade and increase in the growth factors that lead to the end to apoptosis and death of the cell and accumulation of this material, leading to the phenotype, including the hepatosplenomegaly, the skin, and the bones and the CNS involvement. So basically, it is like other mucopolysaccharidosis. It is multisystem disease. And the neuropathic type manifests very early on with CNS manifestation, and basically with developmental delay, which can be identified as early as 2 years of age. Also, some patients, they do present with seizure, however, it is not very common. Okay, hydrocephalus is one of the presentation, behavior changes, and sleep disturbance. Some patients, they present later on with carpal tunnel syndrome. Patients have coarse facial features, short stature. Some of them, they have corneal clouding, not all of them, and corneal clouding is typical of type 1 MPS, but you can see corneal clouding in type 2 as well. Most of the patients, they have recurrent ear infection leading to conductive deafness. However, some of them, they do have neurosensory deafness as well. Teeth can be affected, including caries, cysts, abscesses, and so on. Skeletal system is affected in classic patients with Huntington's disease or MPS1, and they do show what we call multiple dysostosis. And these patients can present with kyphosis, with joint contraction, and so on. And regarding the gastrointestinal symptoms, most of the patients will have hepatosplenomegaly, they may present with diarrhea, with drooling, and the respiratory involvement, including recurrent upper respiratory tract infection, rhinorrhea, sleeping disorder of sleeping. Cardiac manifestation including valvular disease, cardiomyopathy, and arrhythmias as well. Right, so MPS type 2 is really progressive disease, and you can identify two phenotypes. One is rapidly progressive, or what is called neuropathic, and the other one is it is progressive. It is called non-neuropathic. However, CNS can be involved later on. And these patients can be identified as early as first years of life, developmental delay. Especially the patients with neuropathic type, they do present with impaired intelligence, and their life expectancy is 10 to 15 years. So usually they die in their first or second decade of life. They may present with hyperactivity and with seizure, as I mentioned earlier. The other phenotype, which is slowly progressive, these patients, they have normal intelligence. However, intelligence may be declined later in life. They have variable life expectancy. Some of them, they do live up to the 30s and 40s. And they do have very little somatic symptoms like hepatosplenomegaly, coarse facial features. Right, so when do these manifestations present? Well, the earliest manifestation, according to the Hunter survey, outcome survey, is recurrent otitis media. So we need to suspect patients with recurrent otitis media, especially if they have hernia, umbilical hernia as well, and nasal obstruction. So these are the earliest symptoms and signs of MPS type 2. And later on, as time goes, you may recognize the coarse facial features, maybe by the age of 1 to 2 years, and then you will see the rest of the clinical manifestations. So most of these patients require a lot of surgery, especially surgery for adenoidectomy, tonsillectomy, and hernia repair. So please keep an eye on these patients with recurrent need for surgery. They might have MPS type 2. Right, so the early signs are, as I mentioned, nasal obstruction, rhinorrhea, recurrent upper respiratory tract infection. Again, the disease is progressive, and you will start seeing developmental delay maybe in the second year of life. So we need to keep an eye on developmental assessment for kids in the first and second year of life. Right. So what is the differential diagnosis? What other disease mimics or mimic MPS type 2? Well, we need to differentiate MPS type 2 from other MPS, other mucopolysaccharidosis, especially type 1 and type 7, because these three types, they do present with multi-system involvement, with skeletal involvement, and with CNS involvement. The other differential is multiple sulfatase deficiency, and here it's very, very important when it comes to the diagnosis. When you assay the IDS enzyme, you need to assay one of the other sulfatase enzyme, just to make sure you are not missing multiple sulfatase enzyme or multiple sulfatase deficiency. Other differential diagnosis, different types of mucolipidosis, especially type 2 and type 3, and other lysosomal storage disease like monoacidosis and fucosidosis. So these are the main differential diagnosis of MPS type 2. Right, so how do we diagnose these patients? Again, clinical suspicion is important according to the features I already mentioned. So we need really to do skeletal survey, very, very important. And then if the suspicion is high, you do urine for mucopolysaccharides, either quantitative or qualitative. And according to the findings of the urine, then you can send blood for enzyme assay. Either you do one enzyme if your suspicion is high for mucopolysaccharidosis type 2, or you can do multiple mucopolysaccharides enzyme, including type 1, 2, 4, and 6. The diagnosis is confirmed like other mucopolysaccharidosis either by doing sample sequencing of the single gene, IDS gene, if your suspicion is high from the gut profile and from the skeletal survey and the clinical presentation. If you are in the gray area, you are not sure you are doing MPS 1, 2, or others, then you need to do gene panel or whole exome sequencing. There is some effort to develop a clinical score for the diagnosis of MPS, and this is one of these efforts. And this paper was published a few years ago, and they have a score with the letters HUNTER, that is Hunter, and H for hernia, hearing loss, U for unusual faces, and N for nasal obstruction, P for tongue enlargement, and E for enlarged liver spleen, and R for abnormal respiration, including sleep apnea or airway obstruction. So this score was applied to the Hunter outcome survey, and 95% of patients could be identified using this score. However, this is just an academic exercise, I think. Right, so this is just to summarize the diagnosis. So clinical suspicion, first, skeletal survey, then if the suspicion is high, do urine for glycosamine glycan, and again, if you identify heparan sulfate and dermatan sulfate, then your diagnosis, the most likely diagnosis is Hurler, Hunter, or slide, that is type 1, 2, and type 7. And then you can go for enzyme assay, either you assay this enzymes, or you can go for single enzyme assay, that is IDS enzyme, if your suspicion is high. And also you can do sample sequencing for this single gene if you are sure enough. If you are not, then you utilize the gene panel or maybe the whole exome. Right, management of MPS, just like what I mentioned for mucopolysaccharidosis, is a multi-system or multi-specialty involvement, okay, and multidisciplinary team. So all specialties are involved. So how frequently do we involve these specialties in the follow-up? Most of these specialties need to see our patients with MPS 2 every 6 to 12 months, roughly, depending on the clinical features of that specific patient. Right, regarding the specific therapy for MPS, it is like the mucopolysaccharidosis I mentioned earlier. It is either enzyme replacement therapy or bone marrow transplant or both. So regarding the bone marrow transplant, the first patient with Hunter disease or MPS 2 underwent bone marrow transplant was in 1980s. It is long time, almost 40 years. However, the experience with bone marrow transplant for this specific condition is still limited. The advantage of bone marrow, it is only one-time surgical operation. However, the downside of it is, the search for a donor. It's not easy to find a match donor. And also there are, some serious complication and risk associated with bone marrow transplant. So the other option is enzyme replacement therapy, and it is intravenous infusion of the IDS enzyme. It is given weekly, and in most instances you might need hospital admission. However, nowadays some of the patients receive enzyme replacement therapy at home after the first few months in the hospital. Okay, so it is a lot of things need really to be done. So it is it's weekly infusion. It is effective in terms of reducing the glycosaminoglycan in the urine. It also reduces the size of the spleen and liver. However, it has no effect on the CNS manifestation because it doesn't cross the blood-brain barrier. So this is the main limitation of enzyme replacement therapy. It is also very costly type of treatment. Right, we'll talk about the outcome of this too, but let me start with bone marrow transplant. You know, this review was published a few years ago. It is really excellent review. I enjoyed reading it the other day. And the authors here collected 146 patients with MPS who had bone marrow transplant. And out of this number, 27 of them were new cases and 119 were published cases. So this is a huge number of patients with mucopolysaccharidosis and bone marrow transplant. And they compare this with patients who receive only enzymes and with 15 patient untreated cases. Right, so the first message here is none of the 27 new cases died as direct result of bone marrow transplant. So it seems to be the advances in the bone marrow transplant are there, and the mortality is really very little. So we really need to reconsider the position of bone marrow transplant in the treatment of these patients, especially if you diagnose these patients very early. The other complication of bone marrow transplant is graft versus host disease, and this occurred in 9% of the published cases, and 8% of the patients died due to complication of the procedure. So the mortality and the complication are not as we used to have to see. Very important, you know, the data from this review shows that most of the patients who received bone marrow transplant showed improvement in somatic features, hepatosplenomegaly and GAG in the urine and joint movement, as well as the daily living activity. So there is some improvement in the neurological symptoms and signs of these patients. So when you compare this with the enzyme replacement therapy, you know, these patients, they have the advantage of progression or improvement in the neurological symptoms. And this was confirmed by the MRI. So the author concluded their article here by, you know, concluding the article by saying that, you know, bone marrow transplant should be reconsidered as treatment option for this condition. I myself think we need to rethink again about bone marrow transplant for MPS type 2 with maybe enzyme replacement therapy as well, especially if you diagnose this patient early. Right, so moving to enzyme replacement therapy, here this paper was published a few years ago, and it looked at the long-term clinical outcome in patients with MPS. And this study is really extension of the initial randomized control study recruiting patients for enzyme replacement therapy for patients with MPS 2. So the initial randomized control study recruited patients for 1 year. And this extension trial recruited patients for another 2 years. So patients in this study were treated with enzyme, IDS enzyme for 3 years. So just looking at the breakdown of the patient in the first year, in the initial trials, they included 96 patients. 32 patients, one-third, were not given any treatment, so the placebo group. The second group given enzymes with the dose of 0.5 milligram per kg weekly, and the third group was given enzyme replacement therapy every 2 weeks, that is 0.5 milligram. All patients were recruited in the extension study and were given enzyme replacement therapy for another 2 years. So let us see the results. This is a baseline of the all patients. Okay, so what was the primary endpoints of this trial? The primary endpoint is 6 minutes walk distance and the predicted forced vital capacity as well as the absolute forced vital capacity. And the secondary outcome criteria were liver and spleen size, urinary GAG excretion, joint range of movement, cardiac mass index, functional status, and linear growth. Right. So the findings here, I'm just going to go quickly because of the time, and here we can appreciate that the predicted forced vital capacity has improved significantly in patients who received the enzyme replacement therapy for 3 years, and the p-value is less than 0.02. And this is also applied to the absolute forced vital capacity with significant improvement. What about the 6 minutes walk? Again, it is improved significantly compared to the baseline, and the p-value is less than 0.01. Spleen and liver size were improved, okay, and compared to the baseline, and the p-value again is significant. And this is also applied to the joint movement, and they use the shoulder joint movement as indicator of the response to enzyme replacement therapy. And again, here compared to the baseline data, the shoulder flexion and abduction were significantly improved. Looking at the GAG in the urine, also it was decreased significantly. This is the baseline here, and this is after 4 months, 16 months, and after 3 years. I was really surprised by this data on growth rate. The growth rate of these patients is almost normal after enzyme replacement therapy. So the growth velocity was 5 to 6 centimeters, which is normal. So this is really amazing. Okay, also they looked at the safety profile. Like other enzyme replacement therapy, most of the patients, like 60% of the patients, they develop some of the side effects. However, 1/3 of these side effects are serious or life-threatening. And these are the serious side effects: bacteremia occurring in 2 patients, otitis media in 2, carpal tunnel syndrome in 2, sleep apnea in 2, and obstructive airway disorder in 2. So the safety profile is reasonable and is really acceptable. Okay, this second study looked at the long-term outcome of patients treated with the enzyme replacement therapy. And again, this data from the Hunter outcome therapy, and it is really large data. Here, there's more than 639 patients recruited prospectively, and here we have the analysis. Okay, so for these patients, just again, I'm going to go quickly. The 6 minutes walk test is significantly improved in the patients, as well as the size of the liver and the size of the spleen improved, and the cardiac or the left ventricular size, or what they call the left ventricular mass index, here improved significantly. Looking at the GAG in the urine, there is significant reduction in the GAG in the urine. So this data shows the benefit of enzyme replacement therapy in terms of decrease in the size of the spleen, decrease in the size of the liver, improvement in the 6 minutes walk, and decrease in the GAG in the urine. So what about the effect of the enzyme replacement therapy or the survival? Does it improve the survival? Well, this study, which was published a few years ago, they looked at more than 1,200 patients. Okay, and all these patients were recruited in the Hunter survey, outcome survey, and they excluded patients who were recruited retrospectively, that is 166 patients. So, and they also excluded female patients or patients who received both enzyme replacement therapy and bone marrow transplant. So they ended with 800 patients treated exclusively with enzyme replacement therapy and 95 patients who were not treated at all. So they compared these two groups to find the mortality. Okay, I don't have time to go to the detail, but you look at the last row here. In the overall group, which is 895, 152 patients died. In the treated group, 124 patients died, so this is around 15 or 16% of the patient. While in the untreated patients, 28 out of 95 patients died, so that is 30%. So here there is a significant difference between the two patients and the two groups in terms of death. Right, so what about the survival? Well, they looked at the survival and the 95 confidence interval of survival in the treated patients were 33 years, while in patients who were not treated was 21 years. So the enzyme replacement therapy improved the survival significantly. What was the cause of death in these patients? As expected, most of the patients died due to respiratory failure or due to cardiac arrest. Right, so here I'm just going to go through the recent advances in the management of MPS type 2. And the first one is about newborn screening. We have new data about the newborn screening for maple syrup for MPS type 2. Right, so just looking back to the Wilson criteria and ask yourself, should MPS 2 be included in newborn screening panel or not? I think MPS fulfill all the Wilson criteria, which were published in the 60s of the last century. The incidence of MPS more than 1 in 100,000. There is significant morbidity and mortality. There is available treatment. You know, we can argue whether this treatment is successful or not. Okay, and there is reasonable testing cost, not the treatment here, and the technology is available. So it fulfills all the criteria for screening. We have recent data on the outcome of MPS 2 screening, newborn screening, and this is population-based study done in Illinois, in USA, and another data from Taiwan. So the first study recruited 130,000 infants, and they were able to identify 3 infants with pathogenic variants. Okay, so that is an incidence of 1 in 4 to 5,000. In the US, they were able to identify 1 patient out of 160,000 samples. So newborn screening is doable. Okay, and it has the advantage of early diagnosis. So you can start your patient on enzyme replacement therapy, or maybe with a bone marrow transplant as well. However, there are some limitations, including the identification of variants of uncertain significance, identification of patients who are likely to present later, late onset diseases, and this might, present a lot of stress and anxiety among families. So all these things should be considered carefully to include MPS in the panel of newborn screening. Okay, there are other advances in the treatment with enzyme replacement therapy, and basically here people are trying to find access to the brain. Okay, we need to bypass the blood-brain barrier, and here there are many approaches. One is direct infusion of the enzyme in the brain through the intracerebral ventricular axis. Okay, and this approach started years ago, actually, as phase 1 animal studies, and mouse models were infused with IDS enzyme 30 milligram weekly or every 4 weeks for 24 weeks. And this decreased the gap in the CSF. So it has effect on the brain. And also they looked at the mouse and they assessed their memory and learning function, and the outcome is better here. There is some improvement in these two areas. The clinical, regarding the clinical trials in humans, that is started few years ago and it is still ongoing. So we don't have data, and I expect the data to be out by next year. The other approach is to infuse the enzyme through the intrathecal approach. Okay, and here there are many clinical trials. In phase 1 and phase 2 clinical trials, they recruited 16 children, and they found that there is significant reduction of gaps in the CSF. However, most of the patients, they develop side effects related to the device, the intrathecal drug delivery device. They again recruited another 15 patients, okay, and these were treated for more than 200 weeks, and they assessed few of them, and they found that there is some improvement in the neurological outcome of these patients. There is another trial, which is multi-center. They recruited 49 patients. The trial is completed, but we are awaiting the result, and probably it's going to be published next year, together with another trial which recruited patients for 3 years. So we are waiting for the outcome of these trials using the intrathecal axis. Right, so there are another thought and approach about accessing the brain with enzyme replacement therapy. And here the idea is to use conjugated enzyme. Enzyme is conjugated on another molecule like monoclonal antibodies. So this is called the Trojan horse strategy. So you conjugate your enzyme with other molecules to access the brain. And this, they used the monoclonal antibodies here, and they use the insulin receptors and transferrin receptors, to access the brain through the blood-brain barrier. Animal studies have shown that the CSF measurement of the enzyme is really significant, and the enzyme access to the brain is more than 100 times when you give it through the intravenous axis. In the clinical studies just started, and they recruited 14 patients, and we are still waiting for the report of the outcome of that study. Another approach to access the brain through the blood-brain barrier is to use the conjugated enzymes, and there is preliminary report actually on a few patients, and they said there is a good number of heparan sulfate and dermatan sulfate in the CSF, and in 2 patients they showed some improvement in the neurocognitive abilities. Right, this is I just have few slides to go. Bear with me, please. So the other approach is to use the nanoparticle to access the brain and to bypass the blood-brain barrier. And here there are some animal studies using the nanoparticles. And again, the outcome of these studies is really encouraging, and the gag in the brain is less, the neuroinflammation is less. Okay, so this is another promising strategy, and I'm sure we will hear about this a lot in the coming few years. Okay, Dr. Zuhair, laid the ground actually for me and made my life easy by talking about the substrate reduction therapy. And this has success in Gaucher and Niemann-Pick, but not much in MPS2. However, there is one molecule identified that can lead to substrate reduction. Okay, and the idea here is to inhibit the synthesis of mucopolysaccharides. The problem here is because mucopolysaccharides contain a lot of carbohydrates, so if you block one of the pathways, this might affect other pathways. So it is very difficult to find a molecule which can inhibit the synthesis of mucopolysaccharides only. However, there is one molecule called gextamine that was identified, and it is soybeans actually. And the initial clinical trials is promising. It was tried in a few patients and showed some success. So I'm sure we will have a lot of studies utilizing this molecule in the future. Chaperone therapy, again, Dr. Zuhair talked about it, and basically here you use a molecule that favor the correction of misfolded mutated enzyme. And obviously here you cannot use it for all mutation, but you use it for certain mutation with misfolded enzyme. It is approved for Fabry disease, and for MPS it is in really very preliminary phase. However, there is one molecule identified that is working as a chaperone for MPS2, that is called P2S50, and there is some clinical trials going on using this molecule, and probably we'll hear about this a lot in the coming few years. Of course, we cannot talk about the recent advances without talking about gene therapy. Here, I'm just going to talk quickly about the approaches. So there are two approaches: in vivo gene therapy and ex vivo gene therapy, utilizing different type of vectors. So regarding MPS, there are a lot of clinical trials using this approach. However, genome editing using CRISPR-Cas9 is really going to be the future. A lot of studies using this approach. So we are waiting for the results, which are going to be out in the coming few years. You cannot achieve any progress or advances in this field without creating good animal models. And here, the first animal models for MPS2 was created in 1998. And now we have the murine mouse, and even we have the zebrafish, which was identified in 2 years ago or 3 years ago. Okay, so if you look at this here, this is a normal mouse, and this is this is a model actually, and here mouse with MPS type 2 at the age of 3 months, and here at the age of 9 months. So this is really good model, and you can identify the coarse facial feature, and if you palpate this mouse, you will see the hepatosplenomegaly. Right, so there is good progress in that direction. Right, so I'm just going to conclude here by saying we need to have a high index of clinical suspicion to recognize patients with MPS, and we need to do that early in life. There is golden age, the first year, maximum the second year, to treat these patients with good outcome. I think newborn screening is doable, and it is likely to be prevalent in the next few years. Enzyme replacements for MPS type 2 is effective, especially if treated early. However, there is limitation of access to the brain. Trials to overcome this limitation with enzyme replacement therapy is going on, with different approaches, as I mentioned. I think bone marrow transplant for patients with MPS type 2 needs another thought, especially if the patient is diagnosed early. And gene therapy is really promising strategy, so this is the way to go in the coming decade. Thank you very much. I'm happy to answer any question. I think after Dr. Dia presentation.
Okay, thank you, Dr. Sarrar, for this very nice, fruitful presentation and talks. And thank you for the nice, great review of modalities of MPS therapy and treatment. Thank you, Dr. Sarrar, again. Now we introduce the third speaker and the final speaker for today, Dr. Dia Arafa.
Yes, thank you again. I'm sorry for the technical problem. I hope that by changing the router for the net, the presentation will go smoothly. So I will continue from the last slide I stopped on it. So if we take a diet containing amino acid or protein, as we mentioned, phenylalanine is transferred to tyrosine. And the end product of metabolism of tyrosine will formate fumarate and acetoacetate. This is the metabolism of tyrosine. Now, how can tyrosinemia occur? Tyrosinemia occurs because there is a deficiency of the last enzymatic reaction in the pathway for tyrosine. This enzyme called fumaryl acetoacetate hydrolase. There is a deficiency of this enzyme due to genetic mutation. And if there is a block or deficiency of this enzyme, so the pathway will not go smoothly, and we will find accumulation of fumaryl acetoacetic acid and minylyl acetoacetic acid. These two will form succinyl acetoacetate and will cause accumulation of the hazard or risky or damaging metabolite, which is called succinyl acetone. So all the damage happen to the kidney or to the liver in tyrosinemia is produced by the high accumulation of succinyl acetone. Additionally, succinyl acetone cause inhibition of the para-hydroxyphenylpyruvic acid dehydrogenase, which leading to accumulation of hydroxyphenylpyruvic acid, hydroxyphenyl acetic acid, and hydroxyphenyl lactic acid, which can be detected in patients with tyrosinemia in the urine organic acid, and also will cause tyrosine to be high, maybe in moderate accumulation. On the other hand, also succinyl acetone cause inhibition of the porphobilinogen synthase, and this will lead to decreased production of heme and accumulation of delta aminolefenonic acid, which can be detected in urine organic acid. And delta aminolefenonic acid has a neurological impact or damage or injury to the CNS. And this is the cause for the intermittent crisis of porphyria-like episodes. It can cause paresthesia, peripheral neuropathy, disturbed level of conscious, hallucination, and even respiratory failure. So urine organic acid will show these acid, aminolefenonic acid, hydroxyphenyl acetic acid, hydroxyphenyl lactic acid, And most important, the pathognomic marker or metabolite is the detection of succinyl-acetone. So tyrosinemia cannot be labeled as tyrosinemia without the detection of succinyl-acetone. Tyrosinemia is inherited as autosomal recessive manner, meaning that both parents are a carrier, and the likelihood risk for recurrence in next pregnancy, 25% chance to have a disease, 50% of next pregnancy will be a carrier, and 25% will be have a chance of to be a normal. The prevalence, what about the prevalence of tyrosinemia? Because we don't have newborn screening yet in our region. However, we know that from the newborn screening of the 17 disease, including organic acid, urea cycle, amino acidopathy, we have maybe 4 or 5-fold increase than in the other area of the world, mainly because of consanguineous marriage. So we think that the incidence in our region will be higher. But unfortunately, we don't have yet solid figures for the incidence or prevalence in our region. Worldwide, tyrosinemia is estimated to affect 1 in 100,000 live births. It increases in country where there is founder effect mutation, like in Norway and Scandinavian region, the incidence jumped to 1 in 74,000 live births. In Finland, the incidence jumped to 1 in 60,000 live births. And in Canada, Quebec, the incidence is 1 in 16,000 live births, mainly because the French group who settled this area and the effect of founder mutation there. Certain region of Quebec called Saguenay-Lac-Saint-Jean region of Quebec, it has the highest incidence of tyrosinemia, reaching to 1 in 1,846. So as I mentioned, we don't have yet a solid or a strong figure for the incidence in our region, but we think that it is going to be higher than other regions because of the consanguineous marriage. This diagram showing the distribution of gene mutation among the world for patients with tyrosinemia. It is shown that mutation IFS12 constitute about 34% of the cases. Second in order is IFS6, which constitute about 17% of the cases of tyrosinemia. In the Middle East and South Asia, the first mutation or the mutation which have large percentage is the glutamine in substitution with histidine, which constitute about 15% of the cases, and arginine 237X mutation, which constitute about 14% of the cases, and third in number is IFS12 mutation. So this is the mutation detected in the gene FAH gene. The common mutation, as we said, worldwide is IFS12. What are the clinical forms commonly encountered in patients with tyrosinemia type 1? Depending on the onset of manifestation. So if the patient presents in the first 2-3 months of life, this is acute form, and mainly the liver will be affected here. The patient might have hypoglycemia, jaundice, bleeding tendency, hepatomegaly, which progress to ascites. Also, he have liability for infection. Here, the renal involvement or renal tubular dysfunction is less pronounced than in the subacute form. So if the patient present after the age of 6 months, he still have less severe form of liver involvement, mainly coagulation defect. But here, the tubular dysfunction and the hypophosphatemic rickets is more appearing in this age group. And you can smell also in this patient كبجة-like odor اللي هي ريحة الملفوف. They have also susceptibility for infection. The chronic form, which is usually occur after the age of 1 year, the patient have both involvement of the liver and renal. In addition, the patient also has might have infrequent cardiomyopathy, and more striking is the neurological involvement, which come in the form of recurrent attacks of porphyria-like crisis, which come because of abdominal pain, peripheral neuropathy, and hallucination. This table showing the organ involvement in patient with tyrosinemia type 1. As we mentioned, liver manifestation and impairment can lead to cirrhosis on long term and hepatocellular carcinoma. Kidney manifestation, renal tubular acidosis, nephrocarcinosis, osteoporosis, chronic renal failure can present on long term if not treated. And for neurological involvement, the CNS involvement due to the effect of delta amino leuconic acid is presented after the age of 1 year usually, and presented in the form of peripheral neuropathy, respiratory failure, to extent that it need ventilation. And usually each crisis lasting for 7 days. It is more common in untreated French children group. Other systemic manifestation could be muscle weakness due to carnitine deficiency, which is lost in the renal tubules, and cardiomyopathy, and of course, failure to thrive due to chronic illness. Again, the most clinical manifestation encountered in tyrosinemia is liver involvement or hepatomegaly, which is account for 96% of the cases. Rickets and tubular dysfunction, which account for maybe 74 of the cases, especially the hypophosphatemic rickets, because phosphate is lost in the dysfunction tubules. Growth retardation is occur about in 60% of the cases, cirrhosis in 48% of the cases, and carcinoma, hepatocellular carcinoma in 7% of the cases, neurological finding in 7% of the cases. This table showing the common radiological finding in a patient with tyrosinemia in national-wide study in Finland. Because we mentioned that Finland, Norway has, and Canada has high incidence of tyrosinemia. This study showed that 100% of the patients have hepatic nodules. 64% of the cases have rickets manifestation, evidenced by X-ray. 60% of the cases have also hepatomegaly and renomegaly. So in normal hepatocyte, if there is a genetic error leading to a damage, growing damage of the hepatocyte, this on long term causing the unhealthy cell in the liver to rapidly multiply and becoming disorganized, dysplastic cancer cell. And this how hepatocellular carcinoma on long term, usually before the age of 10 years, if the patient not treated, usually how the cancer arise in liver of a patient with tyrosinemia. Again, this is a liver biopsy of a patient with 4 years and old patient with tyrosinemia. We can see in section C, this is dysplastic hepatocyte, abnormal cells due to the prolonged injury to the liver side. If you compare it to this normal hepatocyte, we can see the difference. This is abnormal dysplastic hepatocyte, and we can see in this section the delineated nodule of hepatocellular carcinoma on a cirrhotic background. This is a cirrhosis of the liver, and this is nodule for hepatocellular carcinoma. So if the patient not treated early, he have high risk probability of getting hepatocellular carcinoma. So how to diagnose a patient with tyrosinemia? Some countries, like for example, Quebec in Canada, they run a newborn screening. They are using detection of delta aminoleuconic acid in each newborn, and if it is positive, they go for succinylacetone. I think in the future we will have newborn screening in our country, and I think the central lab will use succinylacetone as a marker for screening for those newborn. But however, if you have a patient with tyrosinemia presented to you with liver impairment, the first thing you do is liver function test, and you will find that there is high elevation of ALT and AST to moderate level. Also, albumin will be low. Maybe a patient will have jaundice also, and coagulation definitely will be abnormal. We will have high BT and BTT due to liver impairment, and ammonia could be high also due to liver impairment. And strikingly, you should have elevation, very high elevation of alpha-fetoprotein, which ranges to average of 160,000. Difficult to accept a patient with tyrosinemia without evidence of high alpha-fetoprotein in the blood. Patient might come also with renal tubular acidosis, like Fanconi syndrome. He might have hypophosphatemic rickets, and there is maybe disturbance or abnormal calcium creatinine ratio. Talking about specific test, you can ask for plasma amino acid, which show high phenylalanine, methionine, and tyrosine, but these are not specific. The most pathognomic and specific marker for tyrosinemia is, of course, detection of succinylacetone, which produce most of the damage to the body. You can find also metabolites, other metabolites in urine, organic acid, like hydroxyphenyl pyruphate, hydroxyphenyl lactate. Also, aminoleuconic acid can be detected in the urine of the patient, especially with neurological involvement. Imaging, as I mentioned earlier, can show multiple nodules in the liver, and X-ray can show evidence of rickets. And of course, the confirmation of tyrosinemia is by doing sequence analysis of fumarate acetoacetate hydrolyze gene, which can show you the mutation. This is the urine organic acid of a patient with tyrosinemia. You can see here peak 1, 2, 3, 4, which is characteristic of succinylacetone, and peak 5 and 6, abnormal peaks in 5 and 6 was characteristic of succinyl acetoacetate. So this is pathognomic finding in patient with tyrosinemia. Patient can have evidence of rickets and tyrosinemia. Here we can see cupping, fraying due to hypophosphatemic rickets and renal tubular acidosis. This slide showing the multiple nodules, hyperdense and hypodense, characteristic of patient with tyrosinemia. You should follow the patient regularly for that, and if it is increasing more than 10 millimole, or if there is elevation of alpha fetoprotein, striking elevation, think about malignancy and think about the option for transplantation. Differential diagnosis for patient with tyrosinemia. If you have a patient if with high tyrosine, this may be due to immature liver or transit hypertyrosinemia, or tyrosinemia 2 or 3, or just high protein diet. If there is high methionine, this may be due to homocystinuria, but we know that homocystinuria is different from tyrosinemia in presentation. Homocystinuria usually have patients have marfanoid habitus, they have lens dislocation and also cardiac involvement. If there is renal involvement, renal tubular acidosis, think about Lewis syndrome, cystinosis, Fanconi syndrome, and eye exam will help in diagnosing cystinosis. If there is neurological crisis, hallucination, recurrent abdominal pain, think about porphyria. But in porphyria, we will not detect succinyl acetone. For liver, any patient with liver disease, there are several disorders can mimicking tyrosinemia, like galactosemia, fructose 1,6-biphosphatase deficiency was associated with hypoglycemia, storage disease like Wilson, Niemann-Pick, or neonatal hemochromatosis, especially if there is cardiac involvement and diabetes, HLH, mitochondria, and CDG, an infiltrative disorder. Small talk about tyrosinemia type 2. In tyrosinemia type 2 and tyrosinemia type 3, remember there is no increase or abnormal accumulation of succinyl acetone. There is no liver involvement. Type 2, usually tyrosinemia type 2 is usually due to tyrosine aminotransferase deficiency. And patients usually have corneal cloudiness and ulcer, obesity, and will have also plantar hyperkeratosis and hyperhidrosis. The treatment is by restriction of tyrosine. In tyrosinemia type 3, it is due to deficiency of hydroxyphenyl pyruvic acid dioxygenase. And this type of disease is very rare and ill-defined. The phenotype is ill-defined form. The first patient to come to attention had an intellectual disability and ataxia. So again, there is no liver involvement, and usually there is a skin and ocular changes. So what is the treatment for tyrosinemia? Remembering this pathway, this is the pathway for tyrosine metabolism, and we mentioned that in tyrosinemia there is deficiency and block here at the level of fumaryl acetoacetate hydrolase, leading to accumulation of toxic material, which is succinyl acetone. So logically speaking, we must prevent this accumulation, which is succinyl acetone. So nowadays there is a treatment called nitisinone, which block the reaction before accumulation of succinylacetone, which blocks the para-hydroxyphenyl pyruvic acid dehydrogenase here at this level. And as a result, we will not have succinylacetone, and consequently, there will be resolution of hepatic and renal involvement. Of course, we'll have accumulation of tyrosine, and this can be lowered by diet restriction in tyrosine. So we need both. We need nitisinone and diet for treatment of tyrosinemia, and this treatment modality increases the survival up to more than 90% of the cases. And nitisinone is the short term is NTBC, and the chemical name is 2-nitro-4-triofluoro-methylbenzoyl cyclohexandione. It is usually given, the standard dose is 1 milligram per kg per day. Some cases, severe liver failure need up to 3 milligram per kg per day. Our target is to maintain. You should monitor nitisinone. You should your target is to keep it between 40 and 60 micromole per liter. This is the chemical structure for nitisinone, and the half-life is 54 hours. Some they use BID regime for young children, and once daily regime oral for older children. So in addition to this specific treatment, NTBC, however, here I need to mention that some author recommend to start NTBC empirically until you have the result for succinylacetone and check the liver improvement after 1 week. Some author say that you should confirm tyrosinemia. I prefer to start empirically because we have limitation in checking up urine acetone, and until we have the urine acetone, urine succinylacetone, or there is improvement, we will decide after 1 week about continuation or discontinuation of the treatment. Also, the patient need also full support for liver impairment. He need correction of electrolytes, fluid, transfusion of albumin, transfusion of blood if needed, vitamin K, correction of coagulation, supplementation of vitamin D or phosphate, and carnitine if there is carnitine deficiency, because we mentioned that carnitine can be lost in the urine. The side effect, the common side effect of NTBC or nitisinone is transit thrombocytopenia, leukopenia, which are transit, as I mentioned, and usually does not need specific management. It resolves by time, or can lead to accumulation of tyrosine crystals and photophobia, leading to photophobia, keratitis. So you should, in addition to NTBC, use special formula restricted of tyrosine and phenylalanine. Your target of monitoring of patient with tyrosinemia is to keep tyrosine below 500 and to keep phenylalanine between 30 and 80 by using special formula for patient with tyrosinemia, restricted in tyrosine and phenylalanine. What about liver transplantation? We mentioned earlier that the only treatment available in the past was liver transplantation, but nowadays there is certain indication for liver transplantation. The first indication is if there is failure of medical management. The second indication if there is evidence of hepatocellular carcinoma. The mortality associated with transplantation reaching to 10%. This table help you in monitoring a patient in the clinic with tyrosinemia. You should check for plasma concentration of methionine, and phenylalanine tyrosine. Also, you should check for regularly for succinylacetone and for nitisinone to keep it, as I mentioned, between 30 and 60. And you should check for CBC also, liver function. And don't forget about alpha-fetoprotein. Which is a marker for cancer, hepatocellular carcinoma. Also, if there is evidence of renal tuberous acidosis, you should check for the calcium creatinine ratio and do X-ray for rickets. This diagram or slide showing the survival for patient not treated for tyrosinemia. And most studies showing that this occur before the age of 10 years if the patient not treated early. We can see here that the survival rate is very low, especially for acute form if they are not receiving treatment early. For a prognosis for survival for treated patient, usually after giving the nitisinone and start the patient on diet, almost of the patients, especially early on the course, they have improvement in the liver function test and normalization after 1 week. Regarding cancer, some studies they said that if patient receive treatment in the first 2 years of life, the incidence of cancer is less than 5%. However, there is one study in Quebec for patient diagnosed by newborn screening. They mentioned that there is no single case whatsoever need admission for tyrosinemia or hepatocellular carcinoma because they treat early, they discover and they do screening early. There is no single case detected after screening and implementation of the treatment. What about prevention? As mentioned by Dr. Zohair, prevention is very important for poor countries who cannot continue supplementation of medication of tyrosinemia. So we can use either pre-implantation genetic diagnosis by taking the OFAM and do fertilization in the labs and examine the cell at 8 cells, embryo at 8 cell stage. If there is tyrosinemia, we will throw it away. And if it is carrier or normal result, we will put it back in the uterus. But during pregnancy, you can do amniocentesis or chorionic filler sampling. And if the fetus has tyrosinemia, we can offer the family abortion before 18th week of gestation. Of course, this can all accomplish if we know the mutation, specific mutation for the family. So in summary, this is an untreated child usually occur before age of 10 years, typically from liver failure, neurological crisis, or hepatocellular carcinoma. We need combined treatment, not all one treatment. We need combined treatment, nitisinone and diet low in tyrosine. Both result in survival more than 90% of the cases. Liver transplantation should be reserved for patients who fail medical management and there is evidence of malignancy. Prevention is very important for poor country, which is pre-implantation or antenatal diagnosis. And usually the organ affected in untreated patient with tyrosinemia is liver, kidney, CNS. Hepatocellular carcinoma incidence is low if treatment started early. So newborn screening is very useful in patients with tyrosinemia. Thank you very much. I have here question to the audience, if time allowed. Can I ask their interaction?
Okay, the time I think is allowed for a few questions, Dr. Dia. Go ahead.
Yes, first question, in hepatorenal tyrosinemia, which is the following enzyme is deficient? You can write in the question and answer the correct answer. Is it glucose 6-phosphate dehydrogenase B amylase, or it is pepsin, or it is fumarate acetoacetate hydrolase, or none of the above? So what is the correct answer for this type of question? Anybody answer in the chat?
I think no.
So the answer is D, fumarate acetoacetate hydrolase. The next question.
Just one of the audience answered D, right, correctly.
Yes. So the next question, what is the treatment strategy for tyrosinemia? Let me show it here. There is mentioned two. There is two strategy for treatment of tyrosinemia. Can anybody answer the strategy? Two. One is medication and one is what? We use medication which change the picture, completely the picture of tyrosinemia type 1. So let me answer this question. Nitisinone, yes, exactly, good, excellent. So nitisinone, and in addition to nitisinone, you should also restrict the patient from tyrosine and phenylalanine. The second question here, what is the important pathogenic test help to diagnose tyrosinemia? There is one test you can ask for it if you have a patient with tyrosinemia, picture of tyrosinemia, and if you detect this test abnormality, you can diagnose tyrosinemia. Anybody know the test or the metabolite?
Please, if one of the audience or attendees can just type the answers if he knows or she knows.
Let me answer this question. The answer is succinylacetone. So if you have a patient with tyrosinemia, detecting succinylacetone is pathognomic for diagnosis. The last question I will ask here, what are the organ system involved in tyrosinemia? Mention 3 organs involved in tyrosinemia 1 disease.
One of the audience answered liver, kidney, CNS.
Yes, excellent. Thank you very much for. By this we conclude my talk, and I hope you get benefit from it. Thank you very much.
Thank you very much, Dr. Dia Arafa. So I think this is the end of the third lecture. I would like to thank all great speakers for sharing all the great knowledge and still the human understanding of the metabolic and genetic science is minute beside Allah subhanahu wa ta'ala. Thank you for the audience and attendees for their patience. Before we start and open the discussion in question and answers, I would like just to, again, for reminding For this webinar, the CME hours will be counted for just some of the medical practice or medical subspecialty. في بعض التخصصات فقط اللي تحسب لهم الساعات التعليمية، منها التخصصات الطبية والعلوم التطبيقية والتغذية العلاجية. كلها ترسلت أعتقد في الإيميل وموجود في البوسترز تلقائيا برقم التسجيل حق الهيئة أو التصنيف. تلقائيا اوتوماتيكلي ستحسب الساعات على حسب التخصص المدرج. فلكل اللي بيسألوا على حسب التخصص هو اوتوماتيكلي تظهر الساعات. أما اللي حضروا سواء في الزوم أو في اليوتيوب لكن ليست من التخصصات المدرجة مثل التمريض حتعطى لهم شهادات فقط. أيضا اللي حضر 70% من الويبينارز ستحسب له الساعات التعليمية. اللي عمل ساين إن وساين أوت لوج أوت يعني بريف ما أعتقد ستحسب له وحيبان عندهم سواء اللي دخل بالزوم أو اليوتيوب. أما اللي بيسألوا عن الحضور في اليوتيوب لأنه الزوم الكاباسيتي فقط حوالي 1000، فاللي ما تسجلوا في الزوم ودخلوا بلينك اليوتيوب فقط يكتب اسمه أو الإيميل إنه حضر في الكومنت في رابط اليوتيوب، فاللي تحسب له الساعات التعليمية. Thank you again. I think we can open the discussion for another 15 minutes for the attendees. Any questions you can type in the question and answer down there. Okay, let's see. Okay, any question from the speakers?
السلام عليكم.
تفضل دكتور سرار. وعليكم السلام ورحمة الله.
Dr. Dia, I just have one question about the status of the newborn screening for galactosemia in the Western province. We know that for tyrosinemia, I mean, we know that succinyl acetone was added, or there is a recommendation to add succinyl acetone to the panel. So is that done in the Western province or is still under discussion? Because in the military hospital where I work, we added succinyl acetone and we were able to detect one patient with tyrosinemia.
Yes, thank you very much, Dr. Sarar. Until now, the inclusion of tyrosinemia as one of the diseases listed in the newborn screening program, national newborn screening program, is not in practical until now. We're expecting that in coming future, maybe in the coming months. It was agreed by the minister, as far as I know, but still not include in the national program. And this apply to all region, not only Western, no, to a region of Saudi Arabia. Tyrosinemia is still not yet included in the national program.
Okay, thank you very much. And what I mean, it is not part of the lecture. What about the other two? I mean, the homocystinuria, methionine. Did you add it or not yet? Because also the recommendation is.
I think there is a plan to include SCIT, homocystinuria, and tyrosinemia, and there is I think CBT disease. But still, until now, we didn't take the approval or the order to run or to screen for newborns, our newborns in the Ministry of Health. I think they are arranging it, but exactly what date they will launch it, I don't know.
Good. And my second question to Dr. Professor Zuhair, there is no data on the
Dr. Zuhair? I think Dr. Sarrar has leaped out accidentally. Okay, there's one question from the audience about the what are the metabolic diseases included in the newborn screen. I think we can direct this question to the Dr. Zuhair or in Dr. Dia, because I think there is differences between King Faisal Specialist Hospital and the Ministry of Health.
السلام عليكم. أنا ما سمعت سؤال الدكتور. ما سمعت سؤال الدكتور.
دكتور سرار I think طلع من accidentally لأنه شكله الإنترنت عنده مشكلة في الشبكة.
حتى أنا
بس كان أيوة، فممكن الآن لما نرجع ثاني. بس في سؤال من الأودينس what are the metabolic diseases included in the newborn screen program. I think both Dr. Zuhair and Dr. Dia can answer this question because I think في شوية أو minor differences between the metabolic screen or newborn screen in the King Faisal Specialist Hospital and the Ministry of Health.
هو شكرا. هو طبعا الناشونال بروجرام اللي started 2005 كان including 16 diseases 14 metabolic و2 اللي هي الاندوكراين congenital hypothyroidism و congenital adrenal hyperplasia. Later on VLCAD deficiency was added فأصبحت 17 مرض with the congenital with the يعني 15 metabolic و2 endocrine. في زي ما ذكر الدكتور سرار والدكتور ضياء في دايركشن او دايركتيف اوردر من السعودي كونسل المجلس الصحي في 2017 انه يضيفوا الامراض اللي ذكرت اللي هي الهوموسيستينيوريا والتيروسينيميا والسكيدز حتى تصير تقريبا 20 مرض واظن البرايمري كارنيتين ديفيشنسي. فهذه المفترض انه كل طبعا المجلس الصحي السعودي يوجه يرسل التوجيه وبعدين كل قطاع صحي يحاول يعني يضيفه بطريقته يعني الخاصه وقته بادجت وكذا. بعض المستشفيات اضافت مثلا الهوموسيستينيوريا مثل الحرس اضاف الهوموسيستينيوريا. فالان يعني لو قلنا 17 مرض 2 اندوكراين وال15 ميتابوليك including amino acid disorder مثل الفينال كيتونيوريا وبعض الأورجانيك أسيديميا مثال مالونيك بروبيونيك ايزوفاليريك بعض الفاتي أسيد أكسيديشن مثل الإمكاد ديفيشنسي والفيل كاد ديفيشنسي ويعني لسته تقريبا اللي هي most treatable diseases والام اس يو دي included طبعا.
Okay, yes, thank you.
Sorry. Yeah, Dr. Zuhair, I think we have a problem with the technical problem as well. I don't know whether you answer my question or not. I was just wondering about your impression about the common types of mucopolysaccharidosis you see in your clinic, because we don't have epidemiological studies. But what I can see in my clinic is basically MPS 4 and 6, the commonest, and then MPS 1 and few of MPS 2. So what do you think? What do you see? Can you hear me? Yes?
انقطع الصوت يا دكتور في interruption sound. تعيد لي السؤال.
Sure. Can you hear me now? Yes?
Yeah, I am hearing.
Okay. I was just wondering about the common types of MPS you see in the clinic. We don't have epidemiological data. So like my impression is MPS 4 is the commonest and 6, and then maybe 1, and we see few of 2. So do you agree with me or you see different pattern?
وطبعا depends on the referral. ما المشكله ما في يعني good data يعني ف we see one mostly like you have said. We see type 6 more Q also we can see, but I don't have good data really. بس اعتقد في مالتي سنتر ستدي بيبر جديده بين الحرس وكينج فهد ميديكال سيتي. They publish new paper, new data about lysosomal storage diseases. حقيقة I haven't read it yet, لكنه I know it was published recently.
Okay, and this lead me to the second question, Dr. Zuhair. I'm just wondering, is there any plan by the Saudi Genetic Society? Can you hear me? Maybe to establish a database. I mean, what I presented in my talk is something like the Hunter outcome study, you know, in the US and in Europe. You know, many countries participated. So here we are in one country, and I think we need to have database for these rare diseases. So any effort from the genetic society point of view to establish such database?
شكرا دكتور. This is يعني demanding يعني data. Always we are requesting this. الآن أظن الدكتورة أمل، ما أدري معنا الدكتورة أمل. I think we have يعني it is mandatory to be done by any way to have good data either for healthcare strategy, long term prevention, screening. طبعا الرول of the society يعني mostly nowadays is recommendation to higher authority and increase awareness of the media and يعني health sectors. طبعا قضية data يحتاج لها a lot of collaboration between different centers, agreement وأشياء كثير يعني politics things يعني ف لكن it is mandatory, it should be done. وأنا I raise my voice also يعني يمكن الدكتورة أمل هي في ماسكة الجمعية ف I think it is يعني has a way to يعني to make it more progressive.
Thank you, Dr. Zuhair. May I interfere in the comment?
Yes.
Okay, thank you, Dr. Sarrar. Thank you, Dr. Zuhair. I think many times we raise this issue in the Ministry of Health to have one registry, local registry of rare disease, either lysosomal storage disorders or other metabolic disorders, such amino acid disorders, carbohydrates and fat metabolism disorders, to have a local in one registry, let's say Saudi, yani all the centers in Saudi Arabia, so governmental or other sectors like National Guard, military hospital, to have one registry for the rare disorders is very important, even to improve the outcome for those patients, even to improve the facility and services needed for those patients. But even among the Gulf area, not only the Kingdom of Saudi Arabia, we raised this issue between the geneticists in metabolic and of the Ministry of Health. But the problem, how we can do this, we should have authority from the Ministry of Health to have this local registry and unified registry. I think it's very important, as Dr. Zuhair said. I think it will solve a lot of problems for the patients and for the services regarding the availability of medications, availability of other services needed for other subspecialty, make it as a one center for those diseases. I think we lack of this. أعتقد if we raise our voices together, maybe to increase it through their webinars or I don't know, conferences and symposium and collaboration, maybe inshallah we will succeed it, yani, hopefully. Also, for the prevalence of the MPS, more commonly, I can see from our patient in Ministry of Health that more MPS 4 and 6 that have the highest prevalence, okay, in the registry of the Ministry of Health. طبعا there is variation between different regions between MPS 6 and 4, but nowadays they're coming equally. But the patients, the prevalence of MPS 4 and 6, it's coming more than MPS 1 and 2. So it may be in the top of the list 4, 6, then 1, 2, and Sanfilippo become the bottom, but sometimes Sanfilippo in some regions will be more prevalent, زي الشرقية, the eastern region. I think they have a lot of cases of Sanfilippo.
هو دكتورة نحن اللي نشوفه يعني أنا الريفيرال مثلا نشوف من الإسترين بروفينس يجينا الموركيو كثير ما أدري ليش أكثر من غيرها. يجينا من الباحة الباحة يجينا الهنتر والهيرلر كثير أكثر من غيرها.
Yes.
But I think يعني الريجستري will find all this geographical distribution of our diseases يعني حتى. طبعا أنا نسيت أذكر دكتورة السعودي كونسل الهيلث كونسل الآن establish committee to proceed with registry الآن على ضوء على مثال الكانسر ريجستري. واجتمعنا عدة اجتماعات الآن ماشيين فيها. الدكتورة أمل معانا إن شاء الله، وفي ريبريزنتيف حقيقة من كذا قطاع، من الصحة ومن الحرس ومن العسكري ومن الهيئة برضو الدكتورة أمل وأنا ومجموعة. مشينا مشوار إن شاء الله، وفي بادجت لها الآن allocated بادجت، فإن شاء الله بإذن الله يعني أتصور خلال السنتين الجاية حيكون في way of registration يعني. شكرا.
شكرا. I think from the audience there is no specific question. So I want to ask you, Dr. Sarrar,
Yes.
For the MPS2 publications and review of the clinical trials for the hematopoietic stem cell transplantation regarding the improvement of neurocognitive delay, do you think it's worth that if we started, even the patient, if he has mild insult of the CNS, just to improve the other visceral organs and skeletal for the hematopoietic stem cell transplantation for MPS2 Hunter? Sure.
Okay. As you know, the recommendation for MPS 1 is clear. You know, if there is if the IQ is above 70 and the age of the child is less than 18 months to 2 years, then bone marrow transplant would be the first option, coupled with enzyme replacement therapy. For MPS 2, there is no clear recommendation. But as I said, because this disease is more prevalent in Asia and Japan and so on, so more studies are done there, okay, compared to the West. But from the article which was published recently, I think the outcome data is really good. And I think this is realistic option. You know, if the patient presented early, especially in the first year of life, I would go for bone marrow transplant with enzyme replacement therapy. Regarding the same scenario for other MPS, it depends really on the facility and it depends on the institute. For example, in the military hospital, we agreed not to treat any patient with significant developmental delay, even if he has other treatable MPS. So it depends on the institute, but I think if the patient presented early, I think this is one of the realistic options. I would start with bone marrow transplant if presented in the first year of life.
Okay, I have another question regarding MPS2. Do you think that if a Hunter syndrome presented mainly with more, of course, neurological insult and like severe ADHD and mental retardation, with less involvement of other visceral organ like skeletal or heart, kidney, liver, and sinopulmonary, do you think it's worth that they are candidate for enzyme replacement therapy? Because I know some countries like Canada, for example, or North America, they are not giving the enzyme replacement therapy for Hunter syndrome who are CNS involved or insulted.
Well, I mean, I would do the same. I mean, as I said, in our hospital, we don't offer enzyme replacement therapy for patients with CNS involvement at all. So if we have even MPS 1, okay, with you know, the IQ is less than 70, we don't offer. I don't think there is point in offering, you know, such expensive medication for someone who's really delayed. I mean, you know, I think this is the least important thing for the patient. The enzyme is not going to cross the blood-brain barrier, so the patient is not going to be helped as far as the CNS is concerned. So if the main presentation is CNS, I wouldn't offer it in the first place.
Thank you. So I think no more questions. Okay. So I would like to thank all the speakers again for the nice, very nice and great talks. I was honored to moderate this webinar with the great speakers and our teachers. Thank you, Dr. Amal Al-Hashim, also for sponsoring this educational program and webinar. I hope, inshallah, in the future will be more webinars and more educational programs. I think we can end this webinar nicely. Thank you, Dr. Amal. Thank you, Dr. Diarafa. Thank you, Dr. Zuhair. Thank you, Dr. Sarrar. Inshallah, see you next time. Bismillah.
Thank you.
Thank you very much. Have a nice day. Thank you.
Thank you very much. And for still the attendees again.
شكرا دكتور أيضا. شكرا دكتور على التقديم وعلى حسن الأداء.
الله يسلمك.
أنت في أي مستشفى دكتورة؟
أنا في الملك عبد العزيز في وزارة الصحة جدة.
الله يحفظك.
الله يسلمك يا رب. So for the attendees again, الحضور الساعات التعليمية حتكون فقط للتخصصات المدرجة. اترسلت عن طريق الإيميل ورسلتها الأخت نادين في الكويستشن and answers. اللي حضروا 70% من الويبينار ستحسب لهم الساعات. اللي سجلوا في اليوتيوب، رابط اليوتيوب، لو فقط يحطوا اسمهم أو الإيميل بالتسجيل المهني أو رقم التسجيل أو تصنيف الهيئة، يعني سيحسب لهم الحضور. فأي أحد سجل تلقائيا على حسب رقم التسجيل أو التصنيف الموجود ستحسب له الساعات أو لا، يعني تلقائيا، ما له علاقة بنفس المنظمين. أي مشكلة حتتواصلوا ممكن عن طريق الرقم اللي حطته الأخت نادين في خانة الأسئلة. شكرا جزيلا لكم مرة ثانية. Thank you for your patience. Thank you.